I'd like to go ahead and get started. My name is Rick Mansur. I'm in the internal medicine department, subspecialty of hematology and medical oncology. I used to be a young physician, but no more. Age happens. I'm going to talk a little bit today about a disease management, how to set up a disease management approach to ambulatory sickle cell disease in the adult population. We're not going to deal with hospital issues or reasons for hospitalization. We're going to talk about the ever-increasing population of adult patients with this disease. Some years ago, sickle cell disease was not heavily represented in the adult population because most of the patients did not survive to adulthood. But with more knowledge about emergencies, pediatric emergencies in sickle cell disease, the realization that a little bit of penicillin every day for the first 5 to 6 years of life prevents a huge number of patients from death, and the advent of very effective vaccinations for pneumococcus, which was a significant reason why patients did not live into adulthood, has caused the emergence of a ever-growing population of adult patients with sickle cell disease. There are probably 100,000 adult patients with sickle cell disease today that need treatment and management. And we have to focus on individual topics for each patient, but disease management includes knowing what's happening to the entire population. I've just come back to the university under a year and a half ago full-time after being part-time for many years. And Dr. Mills asked me to take up the disease management program that didn't currently exist for the adult sickle cell population. And the first thing I discovered was that we had 300 patients. And while the patients were receiving care, they weren't receiving care organized with a goal, directed by any one particular person, and they weren't seeing the same person over and over again. So in some ways their care was fragmented. We had no way of measuring quality or efficiency or efficacy of our treatments. So I'm going to blend that into our talk today, establishing a disease management program for sickle cell disease. Now, it's been known for over 65 years that sickle cell disease is the substitution of an amino acid in the beta globin chain. And it's also known that it's caused by a single nucleotide polymorphism, just a single substitution in the DNA chain that results in the switching from a glutamic acid to a valine in the beta globin. So if that were the total story, that would be a pretty simple concept, because there are about 1.5 million of these things, and if you look around at each other, you'll see the effect of single nucleotide polymorphisms and make us who we are and why we're unique individuals. But unfortunately, for these patients, this single nucleotide polymorphism, while as a heterozygous condition prevents death from malaria in children before the reproductive age, as a homozygous condition, it leads to a soluble hemoglobin leads to it becoming a fiber within the red cell, which is no longer in the liquid form but a solid form as hemoglobin polymers. It'd be like driving a boat in the lake and all of a sudden the lake froze. that is not compatible with the survival of the red cell. So they have a very shortened lifespan. But again, if that were the whole story, if it were simply a hemolytic anemia with no other consequences, we wouldn't see the terrible effects that we see in the patients as they age. 95% of patients survive childhood with hemoglobin SS, homozygous hemoglobin SS disease. So 95% to 100% of patients are delivered to adulthood. And as a group, we've been more or less unprepared to take on these patients. In training, I know you see many patients in the hospital with hospital problems and the terrible crisis, but there's a whole outpatient side to this disease that we need to manage and attempt to prevent those. What was true in 1995 and continues to be true today is that the average age of death for an adult with hemoglobin SS disease remains 45. It's a little shorter for a man, it's a little longer for a woman, but it remains 45 years of age. This is despite all of the advances that have come about in medical care. If you just take the normal lifespan and subtract 35 years, you see the life curve of patients who have hemoglobin SS and some of the variants. So you need to keep this in mind because we're talking about real people with diseases that cause death 35 years earlier than average. And there's a lot of pain and suffering that goes along with this before they become a member of the curve. They don't just live to 45 and just fall over dead. They go through a many episodes of pain and suffering, not just the type that lead them to the emergency room, but infrequently every day of their life, many patients. Now, I want to reinterpret this survival curve so you'll understand this. The cohort that makes it to age 20, if you have 100 in that cohort, every 10 years, 20 patients from that cohort die. So if you look at the percentage death for the 10-year period, 20 out of 100 is 20%, but by the age of 30, when you go from 30 to 40, 20 out of 80 is 25%, and the patients who go from 40 to 50, 20 out of 60, that's 33%, and when the patients reach 50 and there's only 40 of them left, 20 out of those 40, the death rate is 50%, and then 61 to 70, the death rate's 100%. So you have to understand these patients with this in mind because this is a very unpleasant disease for the patients to have. Now what correlates, if you're going to be on the left side of the survival curve as opposed to the right side, the factors that seem to be associated with the left side is an elevated white count. And patients with white counts of 15,000 or higher on the left side of that median survival of 45, and patients who chronically run lower are on the right side. A small number of patients are fortunate to have a high level of fetal hemoglobin, which takes the place of the beta hemoglobin, and it does not sickle. It does not participate in polymerization and failure of solubility of the hemoglobin. And so the small percent of the patients who are above 8.3 are on the right side of the survival curve. Well, I think acute chest syndrome is a very deadly syndrome that we see that's in the hospital, but we'd like to prevent that. There's a high rate of chronic renal failure that moves to renal failure, and those patients are represented heavily in the younger death. So I was looking at the data set in EPIC. Now, I've been working with computers, software, and databases since 1978 when I was a medicine resident. And fortunately for me, I have access to the EPIC reporting system, and I'm able to access it directly and use it for data retrieval. And using various techniques that are used to create a disease management program, which means oversight into a total population, when I compare our patients with a diagnosis of sickle cell disease, which includes 4 types, hemoglobin SS, beta 0 thalassemia S, hemoglobin SC, and beta thalassemia plus hemoglobin S. And then I take out the children. So the patients that we might see, we have sort of the emerging population that were born 1990 and 98. A lot of them are in transition from pediatrics. But we have 109 patients who are in the 26 to 35 year age group. But then every 10 years, we lose half the patients. And so our experience here is either the patients don't survive or they go somewhere else for treatment. It's unlikely that they go somewhere else for treatment. We're having the same death rate here as you can see on the survival curve that I showed previously. We have many patients who come in with pain, and an old study shows that the survival curve for patients with 2 hours per year of pain episodes versus those that are not are this survival curve versus this survival curve. So again, this one is about 40 years. So patients who have a lot of pain, they live, median survival is 40. But remember, that means 50 out of 100 died between the age of 20 and 40. That's a lot of people, a lot of young people who are dying. The patients, from their point of view, they feel like they're expected to look a certain way or act a certain way when they come in with pain, and they don't. They all look different. And so some of them feel like that they're not viewed as being a seriously sick or individual in a lot of pain because they don't meet some perception of a provider who has only been exposed to a very small sample of individuals with this disease. The circumstances of death for adult sickle cell disease. What I want to call to your attention is that there's a very high incidence of the patients who die have on pathology, autopsy exam, have evidence of pulmonary hypertension. And there's a very low incidence of patients dying from drug overdose. So just keep that in mind, that 1% drug overdose, but 15% thromboembolism, there's heart disease, there's cirrhosis. Hopefully we're getting rid of some of this with the hepatitis C treatments. There's endocarditis from these central catheters that they get after their veins are gone, and we're pretty much forced to use them. A fair number of the patients, maybe 10%, end up with renal failure, and they represent those that die. They overrepresent those that die. So we have the desire for a disease management program, but we have no money. Right? Does that sound familiar? You're responsible for these 1,000 patients. We have no budget. Right? All right, so we have very limited resources. Oops, I thought, well, okay. So we decided to focus on some issues. We can't focus on every possible issue for every patient when we look at the whole. We can focus on each patient and try and take care of each patient. But if you're going to measure quality, if you're going to have oversight of hundreds of patients, then you have to pick certain specific issues, focus on those issues, and then try to measure what is happening with the patient population, because no individual physician can see all the patients. So we've picked our disease management based on certain things, such as hydroxyurea is a mild chemotherapy drug, S-phase inhibitor, that the FDA has approved, and it is shown that over a long period of time, hydroxyurea is associated with being on the right side of the survival curve. It does, particularly in pediatric patients, they're able to tolerate a dose that does increase the hemoglobin F, which again decreases the hemoglobin S. But we have a target. It's not so reliable in adults, and it has a lot to do with other genetic factors in the hemoglobin site, the globin gene site cluster, as it's called. So what we do is we try and get the white blood count below 10,000. That's our target. It may not be the right target, but it's a reasonable target. And if a patient comes in and they're always running 15 to 16,000, that pretty much tells us they're not taking their hydroxyurea. We use a lot of transfusion therapy because it's been shown to reduce strokes, and it's been shown to prevent priapism in young men who have that problem. And patients that are having a lot of symptom episodes that are near the median survival, and we know those symptom episodes predict a short survival, we may put them on a transfusion program. Our goal is to get the hemoglobin S to 30%, which is what's been done in pediatrics, but we found that's not really practical. So we're trying to get them between 30 and 40%. I could do the math for you, but it would take a little while. Stroke prevention is key. Now, we've inherited a lot of patients that have very high loads of iron in their liver, heart, pancreas. And an indirect measurement of that is serum ferritin. We have plenty of patients with serum ferritins over 1,000. Of course, ferritin, anytime the liver is inflamed, gets thrown into the blood, and that interferes with the accuracy of the test. We have the ability here to have an MRI scan with quantitative liver iron. It's a non-contrast scan, and it will give you a reliable, accurate, quantitative measure of iron in the liver if you can't quite be sure how much is inflammation of the liver and how much is from iron overload from transfusion. Now, we also have gotten all of our living 10 patients with hepatitis C to go to the clinic for treatment with Harvoni, or whatever is the treatment today. We found also that we have a lot of severe vitamin D deficiency, so we want all of our patients on vitamin D, except a few exceptions that aren't vitamin D deficient. And of course, pain medication is important, and I'll go over that a little bit, but the patients aren't coming if they don't get some kind of pain medication. And of course, they have a lot of pain and suffering, and we'll go over that. But that is between acute crisis, that is chronic pain. So in EPIC, it's easy to graph things, and you can see that this patient who will say, yes, I'm taking my hydroxyurea 2 capsules twice a day, is probably not. And so we give the patients treatment goals. Your goal for your white counts less than 10. Your goal for the ferritins under 1,000. The goal for the vitamin D is not to be unmeasurable, and to be at least, over 20 if possible. And if you're on transfusion, come in on a regular enough basis that we're able to keep your hemoglobin S close to 30. So this patient is failing to take the hydroxyurea. We would like to get that consistently under this blue line. Now, what does a white cell have to do with sickle cell disease? After all, it's insoluble hemoglobin. But whatever the insoluble hemoglobin does to the red cell, eventually it turns out that the white blood cells are involved along with the platelets and the monocytes and circulating endothelial cells, and they all stick together to cause these sickle cell crises. Now, I don't know the etiology of this, but it's kind of curious when people come in and say, I have sickle cell pain, and it just suddenly started, and it's my back, it's my chest, it's my legs, it's my arm, and the first instinct is, well, now how can that be? Didn't it start in one place? But there's something going on, and we have some folks here working on it, but there's something going on that has to do with systemic diffuse process, which leads to microclots and infarcts in very many places. So hydroxyurea, we're targeting to get this granulocyte count down because somehow it's involved with the sickle cell crisis in a major way in the end organ damage. Now, this patient had 94 units of red cells since 2011. And again, I can extract this data from Epic or I can count it manually, but I have a way to extract it and count it for all the patients. And as you can see, this is the serum ferritin. And once we started this patient on a red cell exchange, the ferritin went way up. And that's because all of these units that were given were for crisis where the patients got admitted and got exchange transfusion on the machine where they basically just exchanged the blood that the patient had and gave them 8 units of red cells. That didn't lead to iron overload. But when we took the patient outpatient and started 2 units every 4 weeks, which has been the standard, and he would not take his medicine, for his iron chelator by mouth, his ferritin went right up, and we're going to have to take this patient off transfusion therapy if he doesn't basically straighten up and start taking his iron chelator, because I can't be responsible for poisoning his liver and heart. But that we hope that he'll straighten up. But because of this problem with iron overload, if we take out a unit that has an hematocrit of 20%, we're only getting out 100 mLs of red cells, and then we give 400 when we do this once a month. We're always going to run into iron overload. So we started a program where we take out a unit and give them a unit every 2 weeks. And we encourage them to take their iron chelator. And here's a patient who was up here around 7,000 to 8,000. As you can see with his iron chelator, he went down and then he went back up. We switched him to every 2-week red cells. And he runs his hemoglobin, it runs about 30. He's a young man who had a stroke. He's hemiparetic. He don't want any more strokes. And he's doing quite well. So our goal is to have ambulatory exchanges every 2 weeks, and we're going to always get a little bit ahead on the iron, particularly in the men, and so we're going to use iron chelators to get rid of the excess iron, and we're going to try not to be participating in the problem of iron overload. There was something in the pediatric literature about patients with sickle cell disease having low vitamin D. So we decided to check a few patients, and several patients we checked, the lower limit of measurement is 4.2. And as we continued to check patients, we found that we probably checked a couple hundred, maybe 250, something like that. 49 of the patients are less than 4.2. That's unmeasurable in our lab. And another 99 patients were measurable to less than 11, which is severe. So that's 150 patients, approximately. So we have a severe vitamin D problem in our clinic. Even though the African American population may have a more efficient way of delivering vitamin D to the bones than the Caucasian population, I'm pretty sure that unmeasurable is too low and very severe is probably too low as well. And so we did a little correlation between the amount of opiates versus the vitamin D, and we did find a little statistical correlation between the severe vitamin D patients and the level of opiates that they were requiring. Now, I'm not going to say that one's directly related to the other. There are a number of reasons that someone who has a lot of pain may not get out exposed to sunlight for vitamin D, and we don't know what exact reason is, but there's definitely a correlation. And if you read about severe vitamin D deficiency chronic over a long period of time, according to the literature, those patients have a lot of chronic pain. So we're trying to correct that in our patients. So our team, myself and Dr. Deborah Konda, we supervise the fellows for most of our patients. And Jackie Walton, that's Dr. Mills did provide a nurse coordinator, and Jackie's an experienced nurse and she's doing a wonderful job. Dr. Masters, our senior fellow, chief fellow, and he's done a lot of the data gathering and initial publication I'm going to show you. And of course, all the hematology fellows have they've developed a very good attitude. When in the past, they didn't always have a very good attitude. Not all of them, certain individuals. And our nursing service is understanding how much these patients suffer, and they're treating them, I think, a little bit differently. And then we have a wonderful counselor, Ron Neerman, who runs our support program. Now, this is just some of the patients. There's Ron, oops, sorry. There's Ron and Jackie and some of the patients who are alive as adults suffering with this disease. And this gentleman lived into his 60s and died this year, and he was a role model for many of the patients. He's a very nice guy, and he's missed by those who took care of him and know him. So we want to set goals for each patient and treat them individually, but we have our recurring themes that we want to measure. We want to create some momentum and enthusiasm for meeting the individual goals, both for the patient, like you're doing really great, you've met 2 out of the 4 goals, keep up the good work. And on the provider side, you've got this patient under great control. You know, keep talking to them, encouraging them to keep trying to make the patient successful. And then we're going to look at the entire population by extracting the data. And I have various ways to do that. But it's now I've got it down to I press some buttons, and every week in 10 minutes I pull out all the lab on all the patients, all the meds, all the transfusions, summarize various things, and I can look at our entire population. On Mondays I go to clinic. I've got the 50 patients who are on transfusion, what their numbers are. I've got the 300 patients who come to our clinic, and I've got their certain particular numbers that I'm following, and it takes 10 minutes a week now to update the database. Automated data retrieval is very important. You can't do this by hand or the manual way. And frequent data analysis so that you pretty much know how it's going. It's taken me quite a while to get it to this degree of automation. So here's some results from this year, our academic pursuit. Dr. Master, we were able to pull out 450 patients from our old oncology system in Epic for review. So there were 458 patients. That's one of the largest adult series in the literature, maybe the largest. We also did 100 patients for surveys for various things I'll tell you about in a minute. We submitted 10 abstracts to the American Society this year. We have 1 poster out of that, and the rest are just going to be published in the book. Dr. Master is very energetic and did a lot of this work. And there are multiple residents in the internal medicine program, at least 4, who've done some work with us. We've even been able to participate with basic scientists and supply blood. The patients have volunteered their blood who are on exchange transfusion so that white cell research can be done for inflammatory things that I don't understand on our patient population. And I think it's going to be a great contribution to our basic science department, who's got a big grant to study this. This is some of the data. We have 117 patients had iron overload. That means what we define as ferritin greater than 1,000. That's a big series we've been working on. The majority had hemoglobin SS because they'd gotten a lot of transfusions over the years. They go to the emergency room, any emergency room. They'd have pain. They'd get a couple of units transfused. And so over the years, many of them had a lot of units. A third of the hemoglobin SS patients had had an attack of acute chest syndrome, and 20% of the patients had an overt clinical stroke. Well, there's at least double that, or maybe 2.5 times that many that have had subclinical strokes in non-motor areas of the brain that affect their ability, their cognitive abilities. It's had a big impact. Of these 458 patients, there were 25 who had hepatitis C, but we only had 10 alive currently, and they've all been sent to clinic. And one of our goals is we want every patient treated that needs to be treated. We've had just a few patients with hepatitis B and just a few patients, less than 1%, with HIV. In fact, we only have one patient in our practice now who has HIV. And so some of these patients got this from blood transfusion years ago, and I don't know how the rest of them got it, but it's not a large number, but we want to make sure that they're identified, and we follow them to make sure they get their appointment, they keep their appointment, which is frequently they do not, and so we get them reappointed over and over again until they finally get there, and then we make sure we know that when they've finally been treated. 61% are covered by Medicaid, 25% by Medicare, so this is a good population for the federal government to fund some real disease management programs because they pay for everything. And we do the bulk of the work for Northwest Louisiana, and between us and Conway for all of North Louisiana. Now, the 100-patient survey we did, there were 35% who had depression in the range that would alter their function. 20% had anxiety in this range. The median daily pain medication was 87 milligrams of morphine equivalent. And very few of the patients had, 2/3 had no dental insurance. Some, had Medicaid, which is very limited. And these patients have a high degree of decayed, deteriorating teeth in their late teens and 20s. And they frequently have a lot of extractions by the end of their 20s. Only 16% were employed, and 41 had not graduated high school. Their literacy was low at 99%, even of the entire 100 patients, 99% had the literacy score below the 6th grade level. This is a very poor population. They have no resources. They've had multiple relatives who have not survived very long because they'll tell you, this was my cousin, that was my cousin. It's a big deal for them to come to clinic. Some of them have children. They can't get they can't get help to see about their children. They have to miss clinic. It's a very hard life. Now, in the literature, it says that you shouldn't transfuse patients with sickle cell disease too much because of the dangers of alloimmunization. But see, there's this disease called thalassemia major, where chronic transfusion is done for life, starting at shortly after birth. And there's no reason why a patient with sickle cell disease would have more alloimmunization than that population. So, we have 50 patients who are on exchange, so we have the opportunity with Epic. We extracted all the data from Epic. And believe me, once the routines were built, it takes like 5 minutes. It pulls out, each patient pulls out all the transfusions since basically the beginning of 2012 or sometime in 2011. And the pediatric group had established a policy that patients with sickle cell disease would be matched for big C, big E, and big K, the ones who would transfuse here. Okay? So we had 180 patients, 3,967 instances of transfusion. The way I can count this is that in EPIC, if the patient got the blood, the status says issued. So I can get all the units that say issued, and that means they got it. We only had 25 patients with antibodies, and most of those antibodies were big K, big E, and big C, 27. Some had multiple antibodies, but over half of the antibodies would not have happened if the policy had been applied, to everyone. So basically, this number, 14%, is really only about 5.5%, 6% of the patients will develop these other antibodies if they're matched for C, K, and E. And as far as having blood available, it depends on the donor population. Apparently, our blood bank here is able to tap into donor population where we can match most of these patients, the vast majority of these patients. Now, the elephant in the room. So in a visit, when a patient comes in, they're focused on their pain, all right? And we're focused on not losing our license from the new regulations the federal government has come out. Non-malignant pain. These doctors are given opiates for non-malignant pain, and the patients are selling the drugs, and all these people are dying out there. And I showed you that 1% of deaths from sickle cell disease was drug overdose. That doesn't mean it was a prescription drug. It was a drug overdose, all right? So we're kind of being torn between two things. Paranoia about, the federal government. When they come out, they send you letters from the Surgeon General or whatever. He doesn't say malignant disease and sickle cell disease. He says malignant disease and non-malignant disease. So it's pretty scary. But we can't let these patients suffer. I think there is well, until I lose my license, what we're doing is that we're just documenting very well that the patient gets this many of these a month, and that's what they get, and it's a fairly liberal amount. Now, there are a couple of patients I think that have been pulling the wool over me, but I try not to dehumanize the patients by treating them as a drug abuser, because I may have, 5%, but I don't want to treat 95% in a way that makes them feel different or makes it like I'm accusing them right off the bat. So in sickle cell disease, where the death rate is so high, and as they age, they need to have chronic pain medication. Now, when I first started looking at these patients, I noticed that they all had lots of chest x-rays. They never had any x-rays of anything else. And they complain of back pain, arm pain, leg pain. They rarely say it's my hip. So I started saying, well, we need to start documenting what's wrong with these people, what's wrong with their bones. So this is about a 30-year-old lady, real nice person. And her hips, you would not want to walk on these hips. She puts up with this. I said, can you walk? She said, yeah, I'll walk fine. I said, well, get up from the chair and show me. If you see a patient, tell them to get off the table and watch them walk. Don't just look at them at the table and say neurologically they're intact and their gait and station is normal. So she gets off the table, and she's doing this, and she thinks that's normal. Yeah, I walk normal. But her hips are almost frozen. I don't know how these are projecting, but this bone here, you see we have these light areas and these whiter areas. This is all heavily infarcted bone. This didn't get this way, on a few days. This is a lifelong bone infarction from sickle cell disease with bone remodeling, and you'll see from some CAT scans there are holes in these bones. So this is a grade 4, they say AVN, have a wonderful bone radiologist here, Dr. Simoncini, and he grades all these things. And it's nice because he helps us document why these patients are on pain medicine. How would you like to walk on that? This young fella, he's about 27. He hobbles along. He's afraid to have hip surgery. And you can see that head of that femur's partially reabsorbed. It's flattened. And his whole bone over here is, this is one of the patients, I don't know, multiple of these patients have those unmeasurable vitamin Ds. But everything's abnormal about his bones, you can see. This is another fella. You have to appreciate, this is like a triangle up here. So he had one hip replacement, but this other hip is not shaped, it's not round, it's angular, right in the middle. And you can see there's severe arthritis with this little overhang here and this little point on the hip there. Got one point here, one there. It's called hip impingement. Here's a guy whose femurs are all infarcted around, distal femurs and proximal tibia. I'm doing pretty good as an intern, so I still remember the names of these bones. This is a CAT scan of one of the patients this guy's older. He's like 53. And he's had a lot of pain and, over his life. You can see these holes in the bone, from infarcts. And this is what his lateral spine. I love these new sagittal views and coronal views on these CAT scans because you get all this free information with them. This is just abdominal CT and you get all this good bone information. All these holes in his bone and that destruction, particularly this one that's kind of compressed here. That took a lot of pain to get in that situation. A lot of infarcting going on here. But I tell you, when you look at these patients' chart, all you see are chest x-rays from the emergency department because they hurt all over. When you start x-raying everything, you start seeing why they hurt all over. Now, not every patient has this kind of severe bone disease. But before they had that severe bone disease, they had to have had a lot of diffuse infarction with bones that didn't look like that to get this way. So where do we sit in our little area of the country? What's the need here for a program that really deals with supervision to make sure we have patients getting consistent care and quality? Well, we have a population that's not very large compared to a state like this or a state like this or Michigan. We probably have a third as many people as Michigan, but we have the same number of patients who have sickle cell disease. And in the Medicaid data, this is us. And most of these people, in this particular study that they did, you can see that most of the patients come here for care. This is Monroe. This is around Alexandria. We have about 200 patients from right here, and the other 100 patients that come to us come from these areas. They don't come as often. And this includes pediatrics and adults. In our 310, that's purely the population over who've had a visit at our clinic. I was able to just find all the patients who had a diagnosis in the sickle cell numbering range that had a patient encounter with the number of our clinic on it. And so those patients actually have been to our clinic. So this is a study that shows that a death curve from 1979, when there was a fair number of patients dying in childhood, to a 2006 survey, and see that this bump in childhood death is gone, but there's only a slight shift in the median survival of adults. You see it's right there around 45. So, the patients are still dying of microinfarctions everywhere. And the ones that they know the most about are the microinfarctions in the bone because it causes so much pain. Now this is my little Microsoft Access program. It's hooked into Epic Clarity. Epic Clarity is the reporting database from Epic, and it's updated at least every week because whether I do this Friday night or Monday morning, I have all the week's results up to the week from the beginning of Epic. And the way I have it set up now is I can just press these sequentially, and it takes about 10 minutes, and all these little programs run. They get out all the data, and then they categorize things, like they count the number of, I'll show you some of the reports, you'll see. So in this report, the names were on the left, but this checkbox means the patient's on a transfusion program. This shows that they've had a prescription for hydroxyurea in the last 6 months. They've had a prescription for folic acid within the last 6 months, prescription for vitamin D, and a prescription for one of the iron chelators, either Ferroprox or Deferazerox, in the last 6 months. And then here's their latest ferritin level, their latest white count, most recent, and their latest vitamin D. We don't get a lot of vitamin Ds because somehow Epic stops you from getting vitamin Ds. It throws up a flag and says it's not approved. But we usually manage to get at least one. We break the rules when we can. Now, the 50 patients who are on transfusion program, this is just these patients. This shows the ones that are on hydroxyurea, the ones that are on iron chelator, at least have a prescription for an iron chelator. It shows you their latest ferritin, their latest hemoglobin F, fetal hemoglobin, and then their most recent hemoglobin S from the S monitor. And then these are the number of red cell transfusions in the last 90 days and the number of lifetime in Epic. So I can look at this and correlate. This patient had 7, so he's staying on schedule, but still has an hematocrit hemoglobin S of 46%. This is probably a large patient. It's very bad ferritin. This patient had 7 and has a hemoglobin S of 31%, has a hemoglobin F of 7, which is very high when only a third of the blood is your own, because we've replaced most of it. And the serum ferritin is only 92. So I have all these numbers. I've got all the labs and all the patients, so I can get whatever report I need. And there's several more I need to do, like how many times they've been in the emergency room in the last, 3 to 6 months. This is one little screen I put together. You just pull a patient's name, and it tells you the last white count, the date, hemoglobin F, the date, the ferritin, the date. It changes colors if they're not good. A little series of hemoglobin S's with their date. These are all their prescriptions. And this is all the red cells that they've received since they're in Epic. And it comes up very fast. This is the screen from, just show me patients who had at least one vitamin D measurement that was non-detectable, and this is their latest vitamin D. And again, we're not checking them a lot because Epic throws up a flag that says you can only check this once a year. So it only takes me 10 minutes a week to refresh all the data, and then I just open these reports and look for the numbers I want. I'm not finished with it, but it's a pretty decent start because I'm trying to follow 300 patients. And just so you'll know, this is the kind of computer code that that you can write in Microsoft Access. This particular little subroutine basically counts the number of transfusions in the last 90-day period for each patient in the database that's only the patients who have sickle cell disease. So when I press this routine, in 5 seconds, it tallies it up for every patient. That routine takes 5 seconds to run on the 300 patients. And I write a lot of routines. Oops. Did I get an extra slide there? Okay. Right now, we're just treating the top of the burning fire in sickle cell disease. We've got opiates, we've got folate, we've got penicillin, we've got vaccines, we've got red cells, we've got hydroxyurea, we've got hepatitis prevention and treatment, we've got iron chelators. We're treating all the damage all the damage. Bone marrow transplant, allogeneic, cures children, but it has a 20% death rate from graft versus host disease in a few years, and those children have a 95 to 100% chance of living to age 20. So it's a pretty severe thing to do, and it's hard to find a match. So there are very few patients have had allogeneic bone marrow transplant. There are drugs in research that reduce the stickiness of the cells to the vessel wall. There are drugs that reduce the polymerization that are under study. But gene editing is the real promise in this disease, and it is close. It is close. This is the beta, this is the gene, this is the chromosome area, the cluster. It has the different types of beta globin genes. Well, the beta and then the fetal hemoglobin gene here. And these are the alphas. So you need one of these and one of these make a pair, two pairs make a tetramer, and that's your hemoglobin. And they're not supposed to polymerize. There's not supposed to be more than a tetramer. When they polymerize, they form fibers. This is a gene that produces a protein called, that's been named BCL11A. And this protein apparently sticks right in this area of this beta globin cluster, and when it sticks, it turns off fetal hemoglobin. So when you're born, you have a lot of fetal hemoglobin that gradually goes away at 6 months. And your beta globin comes up, and this is the one with the sickle cell defect. So when children are born, they don't have sickle cell crisis until the beta globin gene begins to replace the gamma globin gene in the hemoglobin. It's called fetal hemoglobin. It's perfectly fine. There are people who only have fetal hemoglobin. Alpha, gamma. And so the drugs that are being investigated to increase or de-repress these gamma genes so that we'll automatically repress the beta genes. But hemoglobin editing has become a big thing with a new technology called CRISPR. And I can't get into that because I don't know enough about it, but what I want to tell you is that it looks like early studies look like it's going to be easier to do something to this part of the gene so that this BCL11A doesn't stick here, and if it doesn't stick here, it won't turn off the gamma, which means the beta won't turn on. So CRISPR, they have two targets. One is to correct the single nucleotide polymorphism abnormality in the beta globin gene, but the second target is to simply stop this interaction here so that the fetal hemoglobin will stay very high and the hemoglobin won't sickle. Well, today with multiple myeloma, we take out the stem cells. We pherese the blood, take out the stem cells, treat the patient with chemotherapy, reinfuse stem cells that are not affected by chemotherapy. The hope for this is that patients will have their own stem cells pheresed. They will be subjected to gene editing with this CRISPR technology. These are basically hemopoietic stem cells that will produce a lot of hemoglobin F and are corrected beta globin. Patient be treated with chemotherapy or something similar, reinfuse the stem cells, and their red cells now will be a mixture of hemoglobin S and hemoglobin A and hemoglobin F, and there won't be enough S that they won't be the sickle cell phenotype. They'll be like a trait. So I think that's coming in 10 years. I hope I live long enough to see it. But that's the end of the talk, and that's what we're doing today. That's what we hope is going to happen, but what I told you before is what we're doing today. Thank you.